Yeah, so I'll start. Okay, let's start the session. This is a very clinical session, and again, probably with a lot of discussion. And I'll start with jet injectors for the treatment of keloids. Here, wait a moment. Here are my disclosures, and oh, it doesn't work. Let's see. Yeah, it doesn't. Yeah, here are my disclosures, of which one is actually relevant because I got a device for free to perform research with, and that was a jet injector. That was, by the way, 8 years ago, so I wouldn't even have to disclose it, but it's certainly a disclosure to mention. So yesterday I talked about different ways how to get the drugs into the keloids, and I didn't talk about the jet injectors, which I'm going to do today. So what are jet injectors? Well, those are devices that create a high pressure jet stream, and if the drug is diluted or is suspended in the fluid, then you can deliver drugs into deeper tissues. If you would like, you could even introduce it into the bone if the kinetic energy of the jet stream is high enough. So you can tune the depth and the volume with some of those devices. So why should we use jet injectors? Well, there's no needle. So in patients with needle phobia, I think it's a good choice. It is painful, but most patients say it's less painful, and if they can choose, a large part would choose the jet injector instead of the needle. You don't have needle stick injuries or cross-contamination if you're doing it the right way, of course, and it's a very fast procedure. Now, there's a lot of force in water, in a jet stream of even water, and it just depends on the kinetic energy. So you can cut through thick stone and steel just with water. And the idea of delivering drugs is quite old. It's from 1866, and this was the very first jet injector that was used to deliver drugs into the skin. In the mid-20s, different spring-loaded jet injectors were developed. This is one that we used until a couple of years in our clinic. I think this is a very known device. You can sterilize it as a whole. And jet injectors were used in the mid-20s for mass vaccination, and very efficiently, because one physician could vaccinate up to 1,000 persons in just 1 hour. So that is a really very quick procedure, and it was used for polio, smallpox, measles, and a couple of other infections. But, oh, by the way, here you see a couple of those old jet injectors that were used for vaccination. But what happened is that there was cross-contamination and also mass outbreaks of, for example, hepatitis B. This is one of the publications from those times. And they kind of disappeared until there were jet injectors with disposable nozzles or jet injectors that could be sterilized, which was not the very first generations. And then there came more interest when the electronically controlled jet injectors were developed, where you can control for the volume and for the kinetic energy of the jet stream, which means you control for the depth of the drug delivery. So actually we have two types. I mean, you could say there are more different types, but basically these two, the spring-loaded one where you typically cannot adjust the volume and the pressure, and the electronically controlled ones. Now, let's see if this video works. So here you see a jet injector, and where a lot of pressure is put on the fluid, creating kinetic energy of the jet stream. The nozzle in this case is 60 micrometer, but for example, the spring-loaded one that you saw and in many of the clinics was present had a 200 micrometer nozzle. which is important for the performance. And then the jet stream is going to kind of pierce through the skin, and it stays very small. It's typically like 200 micrometer in diameter, and it can reach, in this case, down to the muscle if you want to do a vaccination. For us, it needs to stay in the dermis, of course. Okay, let's continue. So the performance of these jet injectors, of course, depends on the jet profile, the nozzle diameter, driving force, the filling volume, and the distance to the skin. But it also depends on the fluid and the drug itself, the density and the viscosity, and on the mechanical properties of the skin, especially the stiffness of the skin and the hardness of the skin, which are different things, and then still some other things, but these are the most important ones. So it's rather a complicated interaction between the jet stream and the skin that should kind of lead to a very controlled drug delivery. That's what the companies claim. In our research, we found out that actually this delivery wasn't really that well controlled as it is intended to be. Now, jet injectors are of all types and sorts. So these are the cosmetic jet injectors that you can buy on the internet for less than 100 euro. And they're online available, and they're filled with hyaluronic acid, so they are intended for rejuvenation. And we did one study because we were interested in the concept actually for medical conditions. And we compared 4 of these jet injectors to medical jet injectors. And we found that they were really very unreliable and even unsafe because there were issues with sterility, there was no CE mark, and several other issues. Now, today, these jet injectors are used for vaccination, for delivery of hormones, but also larger molecules like monoclonal antibodies. In dermatology itself, and this was a review together with my colleagues from Rotterdam, who did most of the work, by the way. And so here are some of the indications and the drugs that have been used for treating these different conditions. Now, one important thing is, and that is because actually the drug delivery is not as controlled as we would like to, it is important to look for clinical endpoints when you treat. And what are the endpoints? One is a papule. So we compared here an electronically controlled and a spring-loaded jet injector. We compared it as a kind of a controlled needle injection. So one important thing is the papule that you create, which means that the drug is, or the fluid is in the dermis and not in the subcutis, because then you don't see a papule. And the other thing is that there's always some splashing and some splatter of the liquid, and that you will find on the surface of the skin. So together with the papule, this is your clinical endpoint actually on how much delivery there really is. And what we saw, it really depends pretty much on the stiffness and hardness of the skin and the properties, because in keloids it's totally different than in normal skin. So if you need a jet injector where you can control for the pressure and also for the volume that you deliver. Now, it's an older principle already, and here there were several studies already done also in scars and keloids. And when we started a couple of years ago together with Rotterdam, we first did, we just started treating patients. And patients had the choice whether they wanted the needle or the jet injector. And then we did retrospective studies. We went on with children once we saw that in adults, that most patients were quite happy with the jet injector. And finally, we did a study with bleomycin also and for keloids. One important issue is certainly if you use bleomycin is that there's aerosol formation. And that is that could be relevant, because if you do a lot of those treatments, you might inhale it and get the pulmonary fibrosis on the long term. So advice from that study was really to use high-powered smoke evacuators when, like you would use with a CO2 laser, when using chemotherapeutics with a jet injector. Another issue is, and that is, I also see that with the normal syringe injections, that sometimes the physician asks somebody else to draw up the Kenalog, the triamcinolone, and once it stays there for a couple of minutes, it's sedimentating. And that's also the same with the jet injectors, because you have to load it, and then typically you wait for some time until it starts up. This is after 10 minutes, and actually all the triamcinolone is here down, and here there's no triamcinolone anymore. So if then you inject, you get a very uneven distribution of the drug in the tissue. Now, and the last study that we did was really, we were interested how is really the distribution of the drug in the skin when we inject keloids, and is that very different from normal skin? And for this, we found a technique, the three-dimensional fluorescent cryomicrotome device, which actually I don't see the, oh, sorry for that. Well, it's a device where a cryomicrotome cuts slices, histological slices of a piece of tissue, and it cuts it every 16 micrometer. And then it makes photographs of every slice, and you have a laser and a certain sensor, so you can pick up fluorescent signals. And if you label the triamcinolone with a fluorescent, then in fact, with this device, it stitches all these, and that may be like 200 slides. It stitches all the images together, and you get a full three-dimensional image of what is really the distribution of the drug in the skin. We compared human skin and keloid skin, and what we found is really a rather bizarre distribution sometimes, like this one here. And keloids, of course, this was done by the jet injector, by the way, but probably the drug finds the way of minor resistance in this very fibrotic tissue. And so sometimes it goes another way than you might imagine it would. And I think this is certainly also a limitation when we inject, that actually the distribution is not what we think. It's not like round or oval. Here is the same in another vision. And we also had, let's see, another one. Here we, oh, by the way, this one was in, because this was done with a needle injection, but sometimes when the keloid is so stiff that you don't get the needle nearly inside, if it's a small needle, or you cannot inject anymore because it's so stiff, then I tend to use a thick needle and perforate the keloid several times, quite a lot of times, and then creating some channels, and hoping that at least the channels will fill with the drug. And this was done in this case. And funny enough, you can see this kind of the spikes where the needle went through the keloid. So I think the drug delivery in keloids is still an issue. And it's different than in normal skin, and it's different than we sometimes think it should be. So I believe that if we still treat locally with injections, then it's also not only important to look at the drugs that we are using, but also on the distribution of the drugs in the tissue. Finally, I'd like to thank my colleagues who were helping and supporting with these treatments and studies, especially from Rotterdam and from the biomedical engineering departments. Okay, thank you for your attention. Shall we keep the questions for later on? Otherwise, we are again Oh, one or two questions. Yeah.
Next presentation.
Over there.
So I've never used the jet injector, but my experience that is very painful. At least that's what-
I tried it on myself. I even tried it on my hand palm. This is really painful, but for the rest, most patients, we did also the pediatric study, and patients had the choice. They got first injection with a needle and the injector, the jet injector. And most of the patients, but not all of them, maybe like 2/3 would choose the jet injector. The jet injector makes a certain noise, and this noise repeats every injection. And if somebody with 100 keloids, patients also get kind of nervous of the noise. But most patients would, it's fine for patients if they can choose something, even though both are painful, actually. Well, no questions?